Luminary presents Therapy versus the World. I'm your host, Joe Nucci, and today I'm very, very excited to share a conversation I had with Dr. Darby Saxbe at the University of Southern California. Dr. Saxbe is a clinical psychologist, she's a researcher, and she specifically looks at why our families seem to get under our skin. She is very interested in social relationships and the biological underpinnings of those relationships. This has led to a natural interest in how mental health information and misinformation gets disseminated, and her and I share a lot of enthusiasm and concerns for all the stuff that is unfolding in mental health culture right now. We discussed everything from artificial intelligence to epigenetics to cognitive behavioral therapy. I learned so much from her each time I talk to her, and I know you will too. Before you check out this episode, it would really, really support our podcast and keep us going if you would take a minute to like or subscribe however you're getting us. Please enjoy, and remember, Therapy versus the World is early ad-free on Luminary. Darby, it's really nice to see you again. I'm excited to be able to chat with you.
Happy to be here. Thanks for having me.
Well, there are so many different directions we can go in. I'd like to just start with the top of the list of different questions that I have. The first is, for those of you who are listening, I initially encountered Darby when she penned this op-ed called "This is Not How We Treat Teen Depression," or it was something like that. Can you tell us a little bit about what was the point of the article, and really for you as a researcher, what the evidence is that you want people to understand?
Sure. Yeah. So I am a clinical psychologist, just like you. I'm actually the director of our clinical training program at the University of Southern California. And I had seen a couple of studies that had just come out reporting kind of underwhelming, disappointing, or even negative effects for a couple of really large-scale treatments that were administered in high schools. So one was an intervention called Wise Teens, which was given to over 1,000 teenagers in Australia. And rather than making teens feel better, the intervention program made teens feel worse, have worse mental health symptoms, and report worse relationships with their parents. And I feel like our field has a lot of interest in kind of light touch, large scale intervention, but frequently the rush to implement goes beyond the evidence base. And so I was kind of inspired to write the op-ed because I think as a field, we need to slow down and make sure that any treatments that we're rolling out are well supported by the science.
Yeah, absolutely. I know that one of the things that you touched on in that article was how a mindfulness or meditation practice or exercise might be really, really not just appropriate, but actually optimal and highly effective for someone in a certain treatment setting, but that might not actually be what's needed for what we might call more like normative or less severe performance anxiety or social anxiety. I think that for people that aren't in the field, that's not the most intuitive concept to understand. How would you explain that in a way that maybe it makes sense?
Yeah, I mean, I think there are a couple of considerations there. So one is the idea of the therapy frame, and that when we go in for treatment, we're going to a very specific place at a very specific time to meet with a very specific person. And in some ways, I think that helps us to kind of unburden what's distressing to us because we feel like it stays in the room where we're expressing those difficult feelings or memories. And so we can sort of better process difficult material when we know that there are strong boundaries around it. So I think that's one piece, is that the kinds of things that work well in the therapy room may not generalize to what we do every day in our ordinary lives or in our classrooms. We might work on specific skills or talk about specific feelings that need to kind of belong in a particular place for us to feel like those things are safe and boundaried. So I think that's one piece. I think the other piece, and I talked about this in the op-ed, is this idea of kind of pathologizing the normal problems of living. So I think there's a big difference between developing skills to be resilient to anxiety and self-diagnosing yourself as having anxiety and then using that to kind of engage in avoidant coping, which we know as clinical psychologists often makes anxiety worse. So there's this term prevalence inflation that refers to sort of people feeling like everybody's got a mental health problem, so they must have one too. And I think when a lot of mental health information is disseminated, that can be an unintended consequence, is that teens in particular who are so tuned in to what people around them are feeling and doing might start to feel like, I need to kind of get on this bandwagon, and clearly there's something wrong with my mental health, because that just seems to be the universal experience of the people in my social world.
Yeah. And any teens who are listening to this, or anyone who used to be a teen, it may not have been explained to you in this way, but when you enter adolescence, when you hit puberty, you're going to deal with certain feelings and hormones, and you're going to be experiencing things for the first time. And that's why adolescence is such a difficult adjustment period for a whole variety of reasons. And so what I hear you saying is that even though the emotions can feel intense, that's actually normal for a teenager. That's what most people go through.
Absolutely. Adolescence is the worst. And, you can have friendships that change, things that are hard at school, awkward or cringy social interactions. Like, all of those things can be part of that kind of rite of passage that all of us go through as teenagers. And I think what is new is when we start to kind of attach diagnostic labels to some of those feelings or experiences, and sort of ascribe an identity that suggests that there's something wrong with us, when in fact we're going through normative transitions.
I do want to bring up, I'm a clinical counselor, just so you know. I don't want anyone to think I'm like faking credentials or anything. But I had an amazing podcast conversation with a researcher based out of Australia. Are you familiar with Dr. Nicholas Haslam? He studies concept creep.
Yeah, definitely.
Yeah. So when it was a really, really lovely conversation. One of the things I loved about talking to him is he was so unbelievably objective about this construct of concept creep that he's been studying for many, many years. And I'm curious, just as someone who's familiar with what that is, it sounds like you might have a slightly different take on it, maybe from being familiar with different parts of literature. And so I know that I tend to take a more kind of a small c kind of conservative, more kind of skeptical approach to a lot of this diagnostic language being employed. And in a weird way, I have this, even my whole, all of the content I've ever made is actually in response to that. Right. And so I was just kind of curious, like from your perspective, do you see the concept creep as it applies to mental health related terms, at least? Is there any evidence coming out, or like studies being conducted that looks whether it can be like good or bad, right or wrong in terms of different populations, whether it's adults, teenagers?
Yeah, I don't know of any recent studies that have looked at this specifically within clinical psych, but I think, intuitively we can kind of resonate with the idea that, the more certain concepts or ideas are kind of like in the ether, the more we're absorbing them, the more we're responding to them, the more we're orienting to them. And I think for a long time in clinical psychology, there was a lot of stigma around mental health and a lot of shame. And a lot of people really didn't feel like they could talk about their diagnoses. And there's been a real effort to disseminate more information about mental health and to dispel some of that stigma. And all of that is great. But then I think, that can lead on the flip side to maybe some kind of overinflation or some elements of concept creep.
As a clinical psychologist and researcher, how do you think about the DSM, the ICD, and these really kind of like formal operational definitions? If you look at the internet, or particularly on social media, and even in grad schools, this was certainly the case when I went to grad school, there seems to be this almost a kind of like a culture of saying, well, this book is culturally problematic, or, this set of symptoms of depression don't encapsulate all of the symptoms of what we understand depression. And so therefore, this is a very kind of limited tool. And while I do agree that there are other ways to view people that are still beneficial, that are not necessarily purely diagnostic, I sometimes wonder if we've actually have forgotten about the importance of construct validity and kind of being on all of like the same page. How do you understand that personally, coming from what you do?
Yeah, in terms of sort of like how much I kind of hew to those
Yeah.
specific symptoms, is that
Right.
kind of what you're asking?
Well, put another way, I understand that as a clinician, I need to be dynamic in how I'm working with the person in front of me. I can't necessarily if they need 5 out of the 9 criteria for some disorder and they meet 4, that doesn't mean I'm just not going to no longer think about this label or how it might be useful. But I think that in this time when information is traveling so fast, both information and misinformation, I'm wondering how do you philosophically approach this idea that these words or these constructs need to be really, really like protected and rigidly defined, or how much room do we have practically to be flexible?
Yeah, that's an interesting question. I mean, I'm coming very much from the research world, and so much of our research is sort of built around the idea that you can operationalize particular mental health problems in really delineated ways, right? So, like, if I'm testing a new therapy for social anxiety, I want people that cleanly fit that diagnosis, and then I'm going to see if I can relieve their specific symptoms. And one of the really problematic things about the kind of like research and practice divide is that in community settings in real life, nobody walks in sort of like perfectly fitting that definition. So a lot of research then involves clients who don't really reflect real world samples, because very few people show up with very straightforward diagnoses and no comorbidities, right? Like most people in the real world
Hmm.
have 2 or 3 or 4 different problems, and they might have symptoms that sort of fit with depression and also fit with anxiety and also fit maybe with something else or trauma history. And so I think it's a really translational challenge for our field to kind of make our research match up with what practitioners are actually doing. And I think it's one reason that there has often been slow adoption of what we consider to be kind of like empirically supported or evidence-based treatments into the community, because I think practitioners rightly will often say those treatments were developed on samples of clients who don't really represent the kind of people that walk into my office.
Yeah. And here's how I handle that. If you have any upgrades or thoughts about it, is I really think of clinical practice, I think of therapy like a craft, much like law or medicine. You can know what all the studies say, you can have read all the books, but are you able to apply it to the person in front of you? And I believe that in particularly in outpatient private practice, how I work, where I am the instrument, the art, the craft of therapy becomes, well, how can I take all this knowledge that I've accumulated and how can I integrate it into my personality? And I'm not very old school analytical with the people I treat. I do let some of myself into the room, but in a way that's for them, always for them. Right. And so that's how I think about it, because I think that you could also leverage this same exact criticism to other fields, other parts of healthcare. Like the doctor you go to every year for your physical. There still is that tension that I think exists.
Yeah, I think that's a really
Yeah.
important point. There's always room for clinical judgment and personalization. And I mean, that kind of circles back to where we started thinking about why might large scale treatments implemented in high school settings not work well. In part, I think because we're using these kind of manualized lessons that are designed to be a little bit one size fits all, when in
Hmm.
fact every client has a really unique history. And I think there's been a lot of interest in, can we use AI models to deliver both um, clinical intervention for mental health, but also like healthcare in general, right? Like, can
Hmm.
an AI tell us what the right drug might be for somebody to go on? And some of that scares me a little bit, because I do think ultimately we need to be able to tailor treatments to the fact that nobody sort of like fits perfectly into a diagnosis and that everybody's experience is really unique. And that's kind of the art that I think is as important as the science, right? Like we are both artist
Yeah.
and scientist when we do mental health work.
Yeah. My dream for AI, at least as far as mental health is concerned, is not so much that, we can have a perfect, little AI chatbot that can deliver competent therapy to everyone. My dream is actually, I would love it if I had almost like a companion with me in the session. And so let's say, you were my patient and then I didn't see you for 10 years and you came back, and then the AI bot was to be like, well, she just brought up her uncle Sam, and she actually brought him up 2 times, like in your intake, but you never really talked about it. Or like just like things that because I'm a person, like I'm not going to have perfect memory, like things I might miss, even if I'm hyper focusing on you every single session. And so that's neither here nor there. That's just kind of a dream I have for the field, because that's something that I think could really help me, actually.
Yeah, I think that's really interesting. Although I also wonder, like, first of all, I think you'd need to train an AI like that, not just on language, but also on things like gesture and voice, and
Totally.
even like the atmosphere of in the room, like, what is the almost like, what does the air feel like? Like, I think there's a lot that like, and this is where I think like the personal judgment comes in. There's a lot that goes on in the room that's actually sort of hard to translate or quantify.
Totally.
And then the other thing that comes to mind when you say that is, I actually think it's good for therapists to forget things and make mistakes sometimes. So I don't know, like in the
Fair
same
enough.
way that you want a good enough parent and not a perfect parent, because you don't want every single one of your needs to be met. You want that friction between your needs and what somebody is able to deliver. And that's sort of like where growth occurs, in that tension. You don't necessarily want a perfect therapist, right? You want a good enough therapist. So a therapist who remembers every single detail of my past experiences might actually not be the best therapist. I want a therapist who can say, remind me what's important about that uncle. I'm sorry if you brought him up before, because then processing that failure is going to advance the therapy, I think, in ways that might be meaningful.
Yeah. And for those listening, because I'm totally picking up what you're putting down, but for those listening or watching, there's at least 2 things, you can add more if you have them, that will happen when a therapist is good enough but not perfect. One is if the patient or client's feelings are hurt, there's an opportunity for repair. There's an opportunity to actually feel closer. But 2, it is very often the case that memory, particularly the meanings we make of our memories and experiences, isn't totally reliable, in the sense that it's not necessarily consistent. And so if I say, I don't remember this family member, can you remind me, what's significant about them? They may actually come forward in that moment spontaneously with more relevant data than what was said before.
Exactly. Yeah, I think it's much more about how the client perceives the memory than it is about the therapist necessarily preserving the exact facts of the memory, right? Like, if I told you a story about something that happened with my uncle, and then 10 years later came to see you, and you remembered every detail of the story, that would actually be less helpful than if you helped me to understand how I felt about the interaction and how it subsequently shaped my relationship with my uncle.
Yeah, absolutely. Speaking of good enough parenting, good enough therapy, have you been able to read, or at least caught any coverage of Abigail Schreier's book,
I
Bad
haven't.
Therapy?
No,
Are you familiar with what it is?
I'm not, but I'd love to hear
So
about it.
it's made quite the splash. So she's a controversial journalist because her last book was about transgender issues, I guess you could say. And she was simultaneously, canceled by Target, but then I think the London Times called it the most significant book of the year. And so she's a very, very polarizing figure. And just a couple of months ago, she came out with this book called Bad Therapy: Why the Kids Aren't Growing Up. The subtitle is something like that. And one of the points she makes is parallel to something that we were talking about earlier, which is her exploration was essentially, why is it that we have never been so concerned with the emotional health and well-being and longevity of our kids and adolescents, and the mental health outcomes are so bad. And she and of course this is it's a multivariate problem. There's, of course, Jonathan Haidt just came out with a book about social media. That's not something she touches too much. There are other things happening, of course, but which her point was that it seemed to her that parents were turning to therapy or therapists as quote unquote parenting experts. And while, of course, I'm obviously a big believer in therapy, even for children and adolescents, and you as well. Her whole criticism, I guess, is that, it doesn't need to be perfect. Feelings can be bad. And there's a lot, there's a lot in there. She was particularly critical of the social emotional learning models being brought into schools, but that's more or less what her book is about. And anyone who's listening, approve of her or don't approve of her, love her or hate her, it's a conversation I think that the field needs to have, because one of the most reliably consistent beneficial therapeutic interventions I've given to parents, particularly new parents, is to unfollow all the parenting experts on social media. You are going to be fine. And just like a lot of encouragement. It is often the parents that can't take that in, and this is my clinical anecdotal observation, and work so hard to not mess up their kid a little bit, end up kind of developing some things that honestly mess up their kids a little bit.
Yeah,
so
exactly. I think that I haven't read the book, but I resonate with this idea that we kind of have an epidemic of anxious over-parenting. So I think that it's only been fairly recently in the last few generations that we even adopted the idea of parenting as a verb, like something that we do, as opposed to something that we are. So the idea that parenting is a full-time job that we need to take very seriously, and we need to kind of pour all our aspirations and effort into shaping our kids, actually turns out to not be that great for kids developing resilience and a sense of self-efficacy and independence. I think that there is a danger of, much like this conversation about the good enough parent or the good enough therapist, there is a danger in being too perfect when we try to meet and anticipate every one of our kids' needs, and we never let them experience conflict or struggle or failure or disappointment. We're not actually helping them build resilience and distress tolerance, which are some of the most important things developmentally that we can acquire and bring into adulthood.
I believe some people might be listening to this conversation, particularly some therapists, and they'll hear words like evidence-based, like distress tolerance, and they'll think, well, Joe and Darby are just a couple of, behaviorists who prefer cognitive therapy. I'm wondering, A, what might you say to people who are maybe more loyal to the more kind of like analytical or dynamic methods? And B, I'm curious if you think that cognitive behavioral methods are easier to study, and that's why they're evidence-based compared to other methods.
Yeah, that's a big conversation. I actually teach this. I teach a clinical interventions graduate seminar, and we talk a lot about, sort of like what's easy to study, what's hard to study, what it means to say something is evidence-based when some evidence is easier to collect than other kinds of evidence. Like, it's hard to study psychodynamic therapies because they're less structured, they're less explicitly symptom-focused, they often last longer. Cognitive behavioral therapies lend themselves well to research, and as a result, they have lots of research support, right? But that doesn't necessarily mean that they're way more effective. I was actually trained psychodynamically. So I had a psychodynamic supervisor when I was a graduate student at UCLA. And I went to an internship site that had a strong psychodynamic tradition. So I like to think of myself as like a neutral party, and I'm kind of interested in what we can take in terms of kind of like mechanisms of change and interventions that sort of cut across treatments. One example would be exposure therapy. We know it works really well for anxiety, right? Like if you're afraid of elevators, the best thing you can do is ride up and down an elevator for an entire day until elevators make you bored, right? You want to habituate to things that are really upsetting, and that's how you build tolerance, and that's how you are able to be less afraid of elevators going forward. I think a lot of the techniques in psychodynamic therapy that involve looking at your past experiences, talking about early relationship patterns. Those are forms of exposure too, even though they're not necessarily
Hmm.
explicitly framed that way. Sometimes you're getting exposure to traumatic experiences or ambivalent feelings. But the ultimate goal is that by kind of like processing those things with another person, you start to become more tolerant of them, right? Like you're bringing emotion into the room, and therefore you're building your resilience to strong emotions. So I sort of think like it's there are lots of different paths to some of the same kinds of outcomes. And the things
Hmm.
that make therapy work really well, like a therapeutic alliance where you can trust another person, and the ability to talk about things that are really hard, those things work really well across more than one kind of treatment.
Hmm. Are you familiar with any literature looking at kind of what would I call it? Like theoretical orientation, like cognitive versus dynamic, and personality? Because I've found anecdotally that my patients who either do score very highly or are likely to score high based on my observation on like trait openness seem to respond very well to a more analytical method. I mean, they remember their dreams, like dream analysis with them is always just so rich and revealing versus, someone who's less open and maybe you could almost think of like, like a textbook kind of like engineer personality. They really thrive on kind of like the thinking about their thoughts and the exposure and like kind of explaining to them how they're going to desensitize themselves to whatever the trigger is that I don't know. I don't know if there's any literature backing that up. That's just something that I've noticed.
Yeah, and there's actually a funny finding that when clinical psychologists who themselves do CBT seek their own therapy, they often seek psychodynamic therapy.
Oh,
So,
amazing.
I think that kind of fits into that idea of, like if you sort of know all the stuff in the manual, then maybe you want to do something different. There's also a lot of research suggesting that the thing that predicts best what kind of treatment is going to work for you is therapist allegiance. So if you're in a treatment study and you have therapists that are sort of doing a couple of different types of treatment, and then you compare those at the end of the day, the treatment that the therapist believes in the most is the treatment that's going to work the best, right? And so I think there are a lot of expectancy beliefs that are wrapped into treatment success. And if a therapist has a lot of confidence that they're going to be able to help you, then I think you start to get better sort of in spite of yourself. But in terms of personality, it's interesting. When I was a trainee, I remember in our clinic, people would come in and we'd do intakes, and they'd frequently ask either for CBT therapy or for psychodynamic therapy. And it was always the people that asked for CBT that we thought would benefit the most from psychodynamic, and the people that asked for psychodynamic that we thought would benefit the most from CBT.
Oh
Because
my
there is something
gosh.
about like it's the engineer mindset that lends itself, that people gravitate to CBT, but maybe it could benefit from some more open-ended exploration of dreams and unconscious wishes. And it's the maybe more loosey-goosey people that like talking about all that stuff that could maybe benefit from the structuring and the behavioral emphasis of CBT. So I think there's also like a paradoxical thing happening there.
Yeah. Absolutely. I mean, you have me thinking about a lot of things with that. I also wanted to, speaking of parenthood and stuff, the first line on your professional website is something like, "Why do our family relationships seem to get under our skin?" And it's such a brilliant question, something I talk about all the time. I mean, to loved ones, to patients, in my content, is I say the best piece of advice I ever got was from a family member of mine, and she said to me, it was my aunt. She said something like, you know, um, you will really learn who you are when it comes to in like work and love. It's within context that the stakes feel higher, that you actually kind of get to meet yourself for the first time. And I'm a big believer in this idea that you can be the most well-adjusted person ever, and your mom says one thing, and you've been to tons of therapy, and done all your work, and you're just you're emotional or you regress or whatever label you want to put on it. And so I'd love to know, well, what got you interested in this question, and then two, what have you found from all the different angles you've looked at it?
Yeah, so I'm really fascinated with the sort of neurobiological underpinnings of close relationships. So that kind of like getting under your skin, both figuratively, like things that really affect us, but also literally, like if we look at our hormones
Mm-hmm.
or if we look at what's happening in our body. I think it's a cool reminder that we're really like primates. Like we have hierarchies and our bodies are shaped by our social experiences, and we're plastic in ways that are affected by our context. So some of the things I've looked at in my lab over the years have been how men's brains change when they become parents. So I found that brain structure is affected across the transition to parenthood for both fathers and mothers. And that for men, it might be linked up with things like their sleep, their mental health, their hormones, which I think is a helpful reminder that there's no sort of like innate maternal instinct that men can't share, that it's much more about the experience of caring for another person that shapes us as opposed to some kind of like preordained biology. So in my lab, I follow expectant parents across that transition to first-time parenthood. And I look at their hormones, I look at their brains, and I look at their social relationships. And I'm just kind of fascinated by the idea of that time as a window of kind of particularly impactful change.
Do you know, is there literature that shows that those changes, because it happens in the action, in the behavior of the care relationship or of the pair bond, if you will, is there any literature that has showed those changes in parents who adopt?
Yeah, there is not as much because there's so few studies that even look at parents who undergo pregnancy. There are even fewer studies that look at adoption. There are just a handful. And some of those have found, for example, there was a study done by Ruth Feldman, who's a researcher in Israel. She looked at gay male couples who adopted a baby, and she actually found that she was able to kind of identify the primary and the secondary caregiver within those couples. And she compared them to kind of like straight mothers and fathers. And she found that the primary caregiver dads had brain patterns that looked just like the primary caregiver moms. And the
Interesting.
secondary caregiver dads had brain patterns that looked more like the secondary caregiver dads and the straight couples, which again just suggests like how plastic we are and that our caregiving roles can kind of shape our biology. And again, it's not about sex and gender, it's kind of about behavior and motivation.
Absolutely. The example you use brings up for me, are you familiar with any of the literature around what we call maybe like more like monogamous pair bonding versus not? One of the better arguments for monogamy in terms of taking on a kind of an individual by individual basis is that there is a lot of kind of biological pair bonding that happens between those two people, versus someone who is single or polyamorous or whatever it might be. What are you familiar with what any of that data says?
A little bit, yeah. So I think I'm familiar with some of the animal research on this. So like one, if you're a hormone researcher who studies relationships, one of your favorite animals is the prairie vole, because the prairie vole is they're pair bonded mammals. They mate for life, and they raise children together. Whereas a lot of other mammals are polygamous. They might have offspring with multiple mates, and it's more about kind of like finding whichever mate brings you the greatest reproductive advantage. So I think how that translates into child outcomes kind of depends on context. But in human families, the most important thing for kids really is just like stability and predictability. So I think that suggests either a monogamous pair bond or some kind of polygamous structure with just like a lot of care and communication built into it.
Is someone who thinks a lot about the hormonal side of some of these psychological phenomenon or mental health, what are a few things that you wish every single, let's say, therapist knew about the biological underpinnings of mental illness? I feel like people on Instagram or kind of like, the intro lecture at a grad school, it kind of talks about like get your daily dose of dopamine, oxytocin, serotonin, endorphins. And then there's your stress hormones, there's your cortisol and adrenaline and norepinephrine, et cetera. But anyone who has kind of double clicked on any of these things know that even something like, testosterone or estrogen has all these different functions and the way it kind of flows throughout the body. What do we know about the more kind of, hormonal side of mental illness that you wish everyone knew?
Yeah, I mean, I think there's a lot of complexity to how hormones work together and how they work with the brain. And I think a lot of that nuance gets missed in kind of the more pop culture translations. So, for example, I've seen a lot of interest in people hacking their testosterone to try to increase their testosterone levels. I've studied testosterone in a transition to parenthood context, and it's actually really adaptive for men's testosterone levels to lower when they become parents. It predicts better outcomes with their partner, better outcomes in terms of their parenting. And so you don't necessarily want to jack up testosterone under every set of circumstances. Like it's totally about your context and what's adaptive in a particular environment or in a particular context may not be in a different context. So I think that's part of it. There's nuance. And it's not just like this level of hormone equals good and this other level of hormone equals bad. Another example of that is cortisol. Like I'm a cortisol researcher, and there's this kind of popular assumption you don't want high cortisol. Cortisol means stress. Cortisol is bad. Actually, you do want high cortisol at certain times of day. Like there's a diurnal pattern to cortisol. You want it high in the morning and you want it to decrease over the course of the day. But chronically low blunted cortisol is actually a sign of burnout and trauma. So, you don't necessarily want to just like cancel out your cortisol. Rather, you want it to be responsive and flexible to your social context. Same with oxytocin. Everybody calls it the cuddle hormone and they associate with love. There's actually some evidence that oxytocin levels are responsive to gaps or deficits in your social world. So people with high oxytocin actually express greater loneliness. So again, like you don't want to focus just on level, like high oxytocin good, high cortisol bad. You want to focus on what makes sense for your like overall social relationship context. And you want to think about like the flexibility or responsiveness of your hormonal systems. Are they responsive to other people in your environment? And are they responsive to changing situations? And ultimately, we all want to be flexible, both in our hormones and in our thinking, because a flexible animal is an animal that can adapt to lots of different circumstances.
Yeah. Absolutely. For all of the biohackers, wellness junkies listening, cortisol is not bad. Testosterone is not automatically good. I'm actually thinking about the what's the herb ashwagandha. At least in other countries, not in the U.S., I've read that it is effective. It seems to be effective at lowering cortisol. But to repeat what you just said, but blunted cortisol response is actually associated with trauma, with depression, with things that don't necessarily feel good. And I know that there are also documented cases of people being on ashwagandha for whatever reason for too long, and then they actually come off of it and they feel way better, even though maybe they had good reasons to go on it when they did.
Yeah, I think another piece of that is like there's no magic pill or magic bullet that's necessarily going to make us feel great. Like a lot of what drives health has to do with our kind of daily behaviors, and rather than any particular like hormone or supplement that we take. There's also the immense power of the placebo effect, which I think is underappreciated when people think about biohacking or about taking particular medicine. Like there's so much interest in psychedelic therapy and ketamine therapy and microdosing. The best studies that have been done on all of those things suggest that they're largely driven by placebo effects. When you give people, for example, ketamine under anesthesia, so they don't know that they're getting ketamine, you see no improvement in mood. So it's really about the expectancy of this treatment is going to help me that is so powerful. And I think that doesn't mean that the treatment isn't good. It actually just means that we should be, I think, more respectful of the placebo effect and how powerful and important it is. And I think, when we take aspirin for a headache and our headache goes away, we think like the aspirin was great. I obviously took the right thing. The fact is, like, there's tons of social context around taking aspirin. There's like the pill bottle, there's what it says on the label, there's the taste of it, the fact that we take it with water, and then we expect the headache's going to go away. 95% of what makes the headache go away could be the placebo effect too. So I just think anytime I hear about any kind of like new treatment or supplement, I always think like how much of that is our mind doing the work, and how much of that is actually real. And the science actually tends to come down on the side of our minds are doing most of the work when, whether it's talk therapy or whether it's pharmacology.
Mm-hmm. I've seen, just anecdotal in my own practice, a lot of success with clinical hypnosis and related techniques. And what I always tell the people I'm working with, I'm like, listen, like the placebo effect is very real, so maybe this will work, maybe it won't. Let's try. We're going to go about it in a way where it's not going to cause any more harm. And I've seen a ton of success with it.
Yeah. And I think like the mind body connection is I think not well understood. And I mean, this is one reason I'm so interested in hormones and brain, because I'm interested in the links between the mind, like how does the mind translate to the body and in ways that can shape our ultimate kind of like physical health. But like people often feel like it's pejorative when they go to the doctor with a physical ailment and they're told like it's depression or it's all in your head. But things that are in your head are legitimate. Like your pain comes from your brain. Just because something's all in your head doesn't mean it's not real. And just because a supplement works for you because of what your mind is telling you about that supplement doesn't mean it's not working. Right? Like, I think, we need to kind of honor the role of our perceptions, our cognitions, our attributions, and our expectations in shaping our reality, because our mind has a really big impact on how we function.
Yeah, absolutely. It's the biopsychosocial model, not just the biosocial model, or not just two of the three.
Exactly.
I remember
we can harness it to do good therapy.
I remember encountering a study just while we're nerding out that, because correct me if I have any of this wrong, but I know there's literature showing that like heartbreak actually activates, pain receptors in the brain, which is why we do our very best to avoid it. And then there was this accompanying study showing that that Tylenol, which actually acts on those receptors, actually kind of blunt some of that social pain. And I thought it was so interesting, just because I know for myself personally, for patients, for loved ones, particularly in those like first few days after a breakup, to have to go to work, to have to like go to these responsibilities, yeah, and I'm not anyone listening to this. This is not medical advice. I'm not telling you to pop a Tylenol, but it did get me wondering. It's perfectly acceptable to pop that Tylenol if you have a low-grade fever or a headache. If you're really heartbroken, if you're really, really stressed about like one of your intimate relationships and you can't focus, you can't get your responsibilities done. I've sometimes wondered. I was like, oh, what if that was more normalized? I don't know.
It's interesting. I actually know the researchers that did that work. They're at UCLA, so I interacted with them when I was a graduate student there. And I think one thing that's really cool that they found that sort of preceded the Tylenol work is that social rejection pain actually shows up in the brain in some of the same regions that process physical pain. So when we feel hurt or abandoned or rejected, it lights up the same part of the brain that lights up when, we get like stabbed. So when we talk about things like, heartache, like that's a very real sensation. I don't know that it necessarily means that we should take Tylenol every time we feel sad. But again, it goes back to that idea of like, we have to honor our mental experiences, our perceptions, like they're just as valid as our sort of physical experiences. And I think there's this idea that if someone has a physical ailment, that's somehow more legitimate or more real than if someone has a mental health problem. And people might feel ashamed about their mental health problem, but, there's much less stigma about their chronic physical health problem. And I would put all of those in the same basket, right? Like, there isn't one that's necessarily more real or that plays out differently in the brain and body than the other.
Yeah, I completely agree. And I don't think that I believe that if people were in scale, in some meaningful scale to take Tylenol every time, the person stopped texting them back or whatever it is. I don't actually think that would be good for you developmentally, because maybe the reason you were rejected is because you conducted yourself in a way that's unacceptable to the person or the group. To your point, none of this is good or bad. Sometimes the rejection or the pain is actually a good thing. People who never feel shame or guilt are by definition, sociopaths. It's okay to feel those things sometimes.
Yeah, and this is kind of goes back to what we were saying about overparenting and the idea that you parent in a way that protects your kid from failure or pain. That may not actually boost your kid's resilience. So yeah, like we grow through adversity. Like I really believe in that. What does not kill me makes me stronger. And, and that's true of physical pain to some extent too. Like, it's uncomfortable and painful to lift weights or to exercise. Nobody loves the feeling of being totally out of breath when they're, out of shape trying to go for a jog. But over time that builds our capacity, right? And I think that can be true emotionally too. Like we can actually, through sort of like minor losses and setbacks and processing failures, we develop strength and confidence to handle bigger losses and failures in the future. Insulating our kids too much from any kind of discomfort is going to have, I think, unintended consequences when it comes to what adolescence and adulthood feel like when they start to get really tough.
Yeah, absolutely. One of my favorite theorists and thinkers on love and romance and heartbreak, his name's Erich Fromm. And he's really cool as far as a theorist goes, because unlike Freud and Beck and a lot of, kind of more known people, he wasn't trained like a doctor. He's actually trained as a sociologist before he became a psychoanalyst. And so he just kind of approaches it from a very, different lens. And one of his theories on love is that it's a craft, it's a practice. You can get better at it, but he kind of has this metaphor of like being able to like open up, like it's almost like a window of tolerance. Like it's like you open up this capacity to give and receive levels of love, but you have to be able to tolerate that bad stuff too. And so that's something I think a lot about, just going back to the Tylenol piece, where it's like, yeah, if you put yourself out there and you break up, like it will definitely hurt. It will definitely hurt if it was real, but you don't get all the good stuff without risking the bad. It's just not how we're designed. And it sounds like there's some, good, even hormonal reasons why we are designed that way.
Yeah. I mean, I think grief and loss are, ways to commemorate love and attachment, right? Like we suffer because we love and because we're human. We don't want to blunt those parts of being human because they're so transformative and important for us. So yeah, I think having a growth mindset approach to life's challenges is better than sort of having a fragile mindset where we feel like every setback harms us in some way. Like, no, in fact, setbacks can make us get stronger and remind us of what's really meaningful and important for us.
Yeah. You also never know how your life path is going to unfold. I believe I've told you at some point off camera that before I found myself really working in like the media space, I explored research, I explored PhDs, and I was rejected, from every program. I couldn't really like build any rapport with any of the researchers. And now in hindsight, I look back and it's like, Joe Nucci, you do not have the personality of a researcher. It's like you're, but talking to people, I love talking to researchers in this medium, in this context. It's actually, it makes me feel just so grateful and full of gratitude and just kind of like alive. And so, but when I was rejected, that wasn't fun,
Of course not.
So,
right. But like every door that closes can potentially point you towards an open door that's a better fit. Right. So yeah, I think you obviously reframed it very well for yourself.
Well, I do love a good reframe as someone who likes the cognitive approach. One last question before we wrap up. Given all that you've learned about kind of like the biological, more hormonal mechanisms of social bonds, et cetera, are you familiar with the more kind of like epigenetic literature?
Yeah. Definitely. Yeah.
What are a few things that you think that mental health professionals or mental health enthusiasts need to know? And I'll preface this by saying that one of the most mind-blowing things, I know you're also familiar with his work, but I remember I was watching a Sapolsky lecture, and he was talking about the Dutch hunger winter, and it absolutely blew my mind. So anyone who's listening, I was like, this is maybe the most important thing I learned that year. It was overwhelming to me in a positive way. Basically, fill in the gaps if I get anything wrong. Basically, they did these studies on pregnant women when there was an embargo on the Netherlands. It was World War I or II. It was
Yep.
during World War II. And it was called the Dutch hunger winter for a reason. Like, a lot of people starved. And the children that were born that spent some time in utero during that period were, had insulin problems, higher rates of obesity, diabetes, all sorts of different things. But the craziest thing for me to learn about that was it wasn't just the children, it was the grandchildren. And so the lesson from this lecture was basically, evolution can happen in a generation, and that's what we're understanding about epigenetics. And so anything you want to say about that, I would love to hear it. But really, what do you want mental health professionals to know? Because I think that there's a real interest in this topic, but it's not something that's really taught about in school, since it's such a new field, and the research has to be done not within psychotherapy and clinical psych.
Yeah, I actually teach about the Dutch hunger winter in my stress and health class that I teach at USC to undergrads. And it's a really important kind of early study that suggests people call this field FOAD, the fetal origins of adult disease, or DOHAD, developmental origins of disease. And this idea that what happens to us in pregnancy can shape our lifelong health and even the health of our offspring. It's really powerful reminder, right? How important it is, that every input that we get is going to shape not just our memories. And if you're a fetus, you don't even necessarily have memories, but it's really going to shape our physiology. But I think one important part of the Dutch hunger winter and other similar research is that there's an adaptation that's taking place, right? So if there's a period of starvation that occurs during pregnancy where there is not enough food to nourish the fetus gets information that the outside world does not have enough calories to sustain me. And as a result, the fetus is going to develop a thriftier metabolism that, and this is why we see like late life obesity and diabetes risk, right? Because we're going to need to make more use of the calories that we're actually able to ingest. And then, of course, you get this mismatch, right? Because there's adaptation to what we perceive to be an environment without enough nutrition. Then you're born into a world where there's lots of food, right? Because the Dutch hunger winter was just this really fixed period of starvation in the Netherlands when food transport was cut off. And so it's not, there's not anything bad about the adaptation. What's bad is the mismatch, is that, the sort of metabolism that was developed during this period of starvation then doesn't fit what's actually available in the environment. And if you think about that translating not just to things like calories and nutrition, but actually to stress, then, what is it like when a mother experiences really significant stress and trauma during pregnancy? The fetus is getting information that the world is risky and dangerous, and I need to be hyper vigilant and alert to threat. And that then develops this kind of behavioral signature of somebody who is maybe easily startled, anxious, might have a propensity to develop anxiety and depression. That hypervigilance can be adaptive in a threatening environment. It's maladaptive in a low threat environment. And that's where we start to see mental health problems develop. So in terms of what I think is important for therapists to know, though, is that none of this is deterministic. So I think we get really excited about the biology. I know I do, like the genetics and the biology and how our brains and bodies are shaped by our inputs and our contexts. But we also have to remember we're plastic. Like, we are designed to be molded by every single learning experience that we have. And so in a lot of ways, interventions can correct for some of these, sort of maladaptive early inputs. There's some evidence that, for example, if you successfully intervene, kids who are institutionally raised, right, who are raised in orphanages where they don't get enough care, if they're adopted early enough into families that are loving, they actually start to show brains and bodies that look more like typically developing kids. So, like there's a lot that we can do, I think, to kind of like change course. And that's where that like growth mindset of mental health is important to keep in mind. Like, we can get better. And again, we can learn and grow from difficult experiences. So I think we want to be interested in the epigenetics, but not in a way that makes us feel hopeless or apt to give up.
Yeah. Absolutely. It's information for us to better understand, to be less judgmental of ourselves and others, but ultimately empower us and motivate us because I'm very much a believer in the growth mindset, just like you. Not that you need to take our word for it. That is also very evidence-based. It's not too much up for debate. And I think that's actually an absolutely wonderful note to end on. Before we wrap up, is there anything else you'd like to leave anyone listening or watching about anything that we talked about or anything else?
I don't think so, but thanks for listening.
Yeah, absolutely. No, it's so fun having you on. We'll have to have you on again. And for those of you who are still listening, remember to please like and subscribe wherever it is that you're getting this podcast. And if you want to listen to Therapy versus the World early and ad-free, you can if you check out Luminary.